to this week's this week's endoscopy session, upper endoscopy session. And just to remind you, this is Gecko in conjunction with the Mexico ECHO project into Africa. And these regular Wednesday meetings are part of that educational exercise. We thank ECHO India for hosting us and providing the infrastructure. So thank you for that. And it's my great pleasure today to introduce someone who is really keeping gastroenterology afloat in Sudan. I've known him now and visited him in Khartoum on 3 occasions when things were in a better state of affairs. He's a consultant physician and gastroenterologist at Absina Gastroenterology Center in Khartoum. So I think he's practicing all over Sudan now, where the situation is very variable in terms of safety and resources. His primary area of interests include hepatitis, HCC, portal hypertension, and when I first met him, he was just establishing an ERCP service in Khartoum. That's about 8 years ago now. And since then, he's gone on to deliver, as you will hear, some of these services in his country. He's been involved with AMAJ, another society which is a branch of the WGO, and he's the past president of that organization. And again, we're going to do some outreach into Rwanda with the British Society of Gastroenterology in late August. So without any further ado, what's happened is that he's online, and he will I'll just let him say a few words just now, and then we're going to play his talk, which he's pre-recorded, because there are concerns regarding whether or not he could transmit it live from his venue. So Abdul, please unmute yourself and just say a little bit, and then I will share the screen and we can listen to your talk, which I'm sure will be fascinating and certainly to myself to hear what you've been doing and how you've been doing it.
Thank you, everybody. Thank you, my friend Sandy Thompson and South African Association for great help for our country. And thank you, Chris. I can see Chris here, and Karim for supporting Sudan gastroenterology training and fellowships. And my great pleasure to be here and present today about our experience in ERCP in Sudan and trying to establish ERCP services in other African countries. Thank you.
Okay, I'm going to go ahead now and share the screen.
Hello, everybody. It's my great pleasure to present in this prestigious forum. Thank you, organizer. Thank you, my friend Sandy Thompson. I will be presenting innovation and maintaining ERCP service in conflict zone. We'll be speaking about the current situation of ERCP services in Africa, the challenges in establishing ERCP service in Africa, and challenges in sustaining ERCP service in Africa, and ERCP service in Sudan, amidst the ongoing war, future plan of supporting ERCP services in Africa. So about ERCP service in Africa is well established in South Africa, in Egypt, and some of North African countries. There is an emerging service in countries like Nigeria, Uganda, Rwanda, Ethiopia, and Kenya in the last 5 years. The challenges of ERCP sustainability in Africa The main challenge is the training and retention of the personnel, because you have highly skilled personnel. They need extensive supervised training, and the training has a long learning curve, and the challenge will be retaining such staff in the country. There is the second major challenge is the cost of the accessories and accessibility of the accessories. Most of the African countries have no distributor for accessories, for the ERCP accessories, and the cost still will be remaining high for African countries. And of course, the third major problem is maintaining the ERCP and repair, ERCP scope repair and fluoroscopy image. And really the major challenge of establishment of the ERCP services, if you look to this three angle of vicious cycle, expert fluoroscopy and scope and accessories. So sometimes you have expert and fluoroscopy and you don't have the scope and accessories. Sometimes you have scope, accessories, and fluoroscopy, you don't have expert. So
Sandy, I can't hear it.
We can't hear it. Can I talk or what? What do you think?
Yeah, just hold on. Sandy?
Sandy, you are unmuted.
Can you hear now?
No, we can't hear it.
as well.
You need me to talk along? Maybe?
Yes, I think if you
The
talk over it.
solution for this, really, you need the training.
Yes, working now.
Short fellowship program.
This-
And you can
Can you speak to it?
And I think it's working now. I can hear it well. Or you need me to speak?
Can you hear it, everyone?
No,
Yes,
no,
we
you've muted it now. You switched it off, but the sound came back. So maybe if he just speaks to it, then we can just continue with the talk.
Yes, I think you speak to it. We can't hear it. I've done.
Okay.
Yes, please talk to it.
Yes, so lack of training, structure training gastroenterology fellowship program. And in the last 15 years, the training program is in Sudan, Ethiopia, Nigeria, and many African countries planning for this. One of the main problems is biomedical engineer and the policy of backup of scope. So in Africa, we don't have this policy, and this policy in Europe. And in developed countries, they have policy, you can have backup scopes, and maybe this included in the price. We have low price scopes, but we have problem with maintenance, of course, leadership and networking and international support. If you combine this, if you have leaders, you can see in many African countries where this service is established is due to have leaders and to have connection, to have international support to sustain these services. So about the history of ERCP services in Sudan, it started in 1988 in Soba University Hospital, and then it started in my hospital in 1986 in Messina Hospital. And by the onset of war, we have 3 governmental centers and 4 private centers, total 7 centers in Khartoum. Next. But unfortunately, the Sudanese war started in April 15, 2023, and mass displacement of people. More than 3 million were displaced immediately from Khartoum, And of course, this lead to collapse of health services. Next. So we need to reallocate to other city. We went 180 kilometers south to Khartoum, to Madani Hospital, and there was a new center which was not functioning. So we started to start a service there. So we proceed for acquiring scope, new scope, C-arm, and ERCP accessories, and to train personnel, 2 young gastroenterologists and nurses, and we have a good load of cases, 60 to 80 cases per month for 2 trainees was good, and by December 2023, in 6 or 7 months, we had 375 ERCP cases, so 70 to 80 per month, and all people coming from all parts of Sudan to this center for this service. Next. So again, the war started in Madani and extended to Madani, and new displacement of people, new collapse of health services in Sudan and ERCP service in Madani. We reallocate to Kassala when 600, this time 600 kilometers to the east part of the country. And really we face many challenges, mostly financial, to get a new scope and to get fluoroscopy machine. Location of Kassala is very far, 600 kilometers away from Madani, and also staff, because there is a loss of enthusiasm of some of our staff. They went outside of the country. So to overcome challenges in Kassala, we managed to get the scope, but we used a fluoroscopy, urology fluoroscopy machine was there. The lithotripsy part was not working, but the C-arm is operational but have some problems, and we work on overcoming them. Next. Back. So this is the urology table, and fluoroscopy, as you see, is the urology table, is not designed for ERCP. We face many difficulties to work with it, so we designed our own table ourselves. Next. So new obstacles we face, that this urology table has up and down mirroring image, and on the people who working with fluoroscopy knows that you have options that you can use left and right, up and down. So it has no it has left and right, but has no up and down. So we have to overcome this. It also has fixed screen limitations, the screen just for the urology man and for the fluoroscopy. You don't have another screen. And also limited fluoroscopic exposure, because the motor is small. I mean, is exposure time. If you do more exposure, you will lose, the machine will stop working. So to solve the problem of up-down reversal in image, my nurse suggested just to put the screen back. If you can see, the screen is up down, and then we managed to overcome this and started to do some cases. Next. So if you can see, we did the first 2-3 cases with just single screen at fluoroscopy side, and we didn't have another screen, so we have to see together with a fluoroscopy man, and it was difficult, and the exposure time for screen was higher. So we tried through our biomedical engineer to improve this and to solve it, but it didn't work. So we went ourselves with our IT engineer for new solution. Next. So we got this DVR system, security camera and DVR system to get the another screen. So we managed to get the screen, as you see, the 4 icon from the fluoroscopy, and it can show you can take image from this scope screen and from fluoroscopy. You can get the 2 images. So we managed to solve this problem. Next. So the DVR, the digital video recording system, was good that is a real-time displaying the screen, and you also procedure, you can review the cases and you can monitor your trainee, and you can do quality assessment or assurance for what you did, and also you have recorded data there, and also it is potential for education. You can we plan to do, if you put a fixed camera, then you can use it for live demonstration. Next. As you see this, the DVR camera showing 4 icons. Next. So if you put a security camera or any camera, as you can see, we just put a security camera, combine it, and then we use it. But you can use any type of cheap camera, or and then we can use this software. Most of you maybe know it. You can monitor your house away, so you can monitor the cases away where you are. You monitor your trainee. You can access the data if the DVR is open at any time. So and you can monitor your trainee while working, and you can come and help, or if you can advise from away. Next. This software is very nice. Thank you, Sandy Thompson. He advised to use this software instead of getting mixture, and this me monitoring my trainee while in the center upstairs, and they are doing the procedure downstairs. I'm ready. If they need me, I can come at any time. You can see this is the trainee. He's doing the case, and if he will call me, I'm monitoring his mobile phone. I can come and get help. And this Muhammad Yusuf from UK saying the case. Our radiologist in Egypt also following with us the case and discussing the management of the case. Next. No, before it. Yes, and this while last week while I'm in DDW, my training were doctors doing the ERCP, already independent, monitoring them. As you can see me down, speaking to them. This one of them, Dr. Halan, and doctors Hussam from UK, that come and did the case with them. So we also face many challenges in having accessories like the pre-cut. When we started, we don't have pre-cut. We have 10 French pusher, but not 7 French. So we have to create them. I will show a short video about creating this, the pre-cut from snare and pre-cut from synchrotome, and you can watch the video. No, go back. Can you go back? Yes, just start video, let the video okay. So you see this snare, you cut the loop of the snare and you get one side of the loop, then you have a pre-cut. And really, I love this pre-cut. Even I use it when I have even new the original one, but I like this pre-cut very much, and it's worked very effectively in cannulating patient. This patient, I think, has proximal stricture. So I went and selective cannulation, as you see, very successful. So also creation a busher for 8 French stem. This injector, you just cut the tip of the injector, you get the sheath out of the injector, inject the needle itself, and then through the sheath you can insert the guide wire and you can use it as pusher. Yes, successfully we use it as pusher. So sphincterotomy, you know that we reuse the sphincterotome until it will not work. So you can cut the end of the sphincterotome and use it as well as pre-cut. So this, we use it for impacted stone in the ampulla, and we managed to cut and cannulate successfully. Very efficient, and it works very well. So in Madani, we did 375 cases in 5 months, as I said, average about 70 procedure. 2 trainees were trained. So in Kasala, we did 520 cases. Maybe this in 10 months or more, not 7 months, about 50 procedure per month. The number and the volume less than Madani because the center is far east and people cannot come to these centers. But some people getting 10 hours to go to our centers, and some people maybe 2 or 3 days to reach us to do this, the ERCP. This is why we are very eager to train other gastroenterologists to go and do ERCP and to establish ERCP service in other areas. So we trained another 2 gastroenterologists, so 4 trainees, 3 now doing independently, and then one, the 4th trainees, I think in 2 months will be ready for doing the training. So this is the average age of our patient between 60 and 69, and also next slide. They are coming from all parts of Sudan, as you see, but in the east part, of course, the large number is coming from this area. And the pathology, you can see distal, mainly stricture, distal and proximal strictures, then stone. If you combine both them, you can see the strictures, the malignant stricture is more. You have ampullary tumor as well. And some cases come with cholangitis infected bile. Next. So our pancreatitis cases, go back, pancreatitis, we have 9 cases of pancreatitis, and 5%. We don't have NSAID, but we use aggressive rehydration to avoid pancreatitis before and after procedure. We had 1 case of perforation and no sedation-related complications. Next. So we did a training workshop as we have demand for more doctors doing ERCP. So despite of war, we did training workshop in Port Sudan with support of our Federal Minister of Health, with support of the police hospital who managed to get scope and all set of ERCP. So we did the training workshop very successfully. This is my team going to Port Sudan from Kassala doing the workshop. And 3 days workshop esophageal for ERCP and esophageal stenting. East part of Sudan have many esophageal cancer. Next. So we had a trainee from 10 cities from Sudan. It was very successful and well attended. And this was published in newsletter, the WGO newsletter. And we had one of the experts come from USA, from Sudanese American Physician Association to help in this workshop. And really it was a good start of collaboration with SABA. And even my travel now to the UW was arranged by SABA. Next. Yes, we use in this workshop our innovation, live transmission. We transmitted all the cases because we have four group of trainees. They cannot go all to the ERCP room. So 1 group going to the ERCP and 3 group attending the discussion using our solution transmitting without high cost of live transmission. And also we did the training modules. In Khartoum, we have a very good training modules. Sandy visit us, and also we get even electronic modules, but we lost all of them in Khartoum. So we design our low-cost ERCP training module ourselves. This is our training module, ERCP module, if you can see. Is very efficient. His idea is just to reduce the scope, to put it in a position for cannulation in a short way. So I'm explaining to the fellows, and I see from the training, all of them, they manage to reduce the scope to get the ampulla, and to show them with just little movement, you can change the position, you can access the cannulation, and the most important to get them pulling in the position, then all experience in ERCP will come if you manage to maintain your position. Even all the fellows in all groups, 4 groups, managed successfully to do this with our training model, and I can assure you is a good model. I trained in models, and this is a good. Also, we did an esophageal stenting model as well. Yes. So as I said, in east part of Sudan, we have a lot of esophageal cancer. Really, this area we need to collaborate with West, maybe as African also, in studying the malignancy in cholangiocarcinoma, CA pancreas, and CA esophagus in our region. So it works very well. We create just a structure, and we demonstrate how you can manage to do the stent. We use this very small pediatric scope, so it can you go without fluoroscopy, doing scope by side, scope side, going by side of the scope. And if you see this, where we put the stent in the end, and this is the beginning of the stent, and you can go with the small scope through the structure as well. This structure is a black one. Next step, maybe we'll change the color to make it light, but this is a start. Thank you. So we consider the ERCP fellowship program as having this high volume, and we have a long discussion with my friend Sandy. Caring to assess the trainee, because going through DOPS is a long, and I think getting our own score for scoring patients is result of this long discussion with my friend Sandy Thompson as well. I discussed with him the trainee, and he has some suggestion to improve the score. So we develop our own score. You start using this score after just 50 supervised. So you do first 50 supervised cases, then you start using the score to assess the upcoming 50. So the total number is 100 cases to assess the trainee. And as you know, in many guidelines in USA, in Europe, you need 175, maybe some centers 200. But we tried this and trying to validate it in 100 cases, 50 first with like monitor, just supervise, and 50 using our electronic model assessment filled by the trainee. Next. So the idea is that the case complicities, we name it Sudan Trainee Assessment of ERCP Abdo State Score. So the case complicity, if the case is complex, you get 3 points. If moderate, 2 points. If no complicity, you get 1 point. The total of each component is 6. Is 3. So requirement for supervision, so either 0 or 3, you get 3 points. And then if you need assistance, if you don't need assistance, this 0 point, and then you have, if you do post the first complex case, a requirement, no requirements of supervision, so you get total 6 score. If the supervisor himself failed to get, then you get 3 points, and if you have like moderate score, so you get 5 points. So total of assessment is total, the highest score is 6. And then next slide. So if you assess trainee in 50 cases, if the trainee get 250 points and plus, he can go independently and practice ERCP, but you need to monitor his competency in 6 or 12 months using the same score. And if the trainee get 200 to 250, so he need targeted training and reevaluation and additional training focus on weak areas which identified by the same score. If the trainee get below 200 points, so he need extended training and period of assessment. So we have a plan. We applied this proposal to WEO for this was like 3 or 4 years ago, even before war, to use support of WEO, AMAD, IGAD, and Arab Fund of technical assistance in African countries. And the idea is that we have to choose 4 side countries and do a committee to select these countries. Next. So the criteria, the political willingness to support governmental center to sustain ERCP service, covering cost of accommodation locally and transport and living cost for the visiting expert. And of course, availability of equipment, the core equipment, duodenoscope and fluoroscopy. And then you can use our Khartoum Training Center raising fund to get tickets for expert. So you get visit every twice a month, 2-3 days prepare cases. After, of course, you do first induction course on models, then you have trainee working with expert coming every twice a month, doing 2-3 days training. I supervised training and live cases. Next. So we are planning now our first step going to Tanzania. We get fund from some of institution in Tanzania funding. Now we are funding this visit, and we are now in process of the checklist. The core equipment, duodenoscope and C-arm are there. ERCP accessories can be managed if even missing. We are just checking with the nurse there. Drug anesthesia, IV fluids, and prophylactic, like I said, also are there. So we are planning to start with Tanzania soon. Next. So I will end with our center. Madani is back again. The Sudanese army get back Madani, and most of displaced people came back to Madani. And this our very nice center now start working again. My trained fellows went back to Madani, restart the service. Now they are from their clinic. And this is a visit of Minister of Health, encouraging staff and thanking them for working hard and trying to reestablish the service. And this our ERCP room will show you, and we'll end it with this. Yes, this is our ERCP room and ERCP setup in Madani is very good, nice setup. They start already did 3 or 4 lists in the last months, and they will keep doing ERCP service. And this is a theater, is state-of-art theater really, is modular OR, waiting for all GI services. We plan to do all GI, our upper and lower in hepatobiliary, but the invasion of Madani stop all this. We started with the ERCP then, but we will do the surgery as well. Thank you very much.
Thank you very much, Abdel. I certainly enjoyed that. I hope the quality of the sound was quite good in the end.
Yes, yes.
And we could understand what you've been up to. I think it's an amazing journey you've been on. I think many people would have given up long ago with the obstacles that have been put in your place. So from me, it's a sort of testament to how you can do it. I've also been involved with trying to set up units within South Africa. Again, the sort of size of the population and the venues for ERCP are still limited, particularly within the state sector, even in South Africa. And yeah, it's a difficult problem. I don't know if there's any questions in the chat box. But I'm not sure if any of your compatriots are on the call, if they would like to say something. I'm not sure where everybody's from, but it looks like some of your compatriots are on the call.
Okay.
Can you recognize any?
Let me see. My mentor, Professor Fidel, is here.
I see
hear from him?
Professor Fidel, would you like to unmute?
Can you unmute Professor Fidel?
And say a few words?
Hello.
Yes.
Hello.
Hello,
Go
Sandy.
ahead.
Thank you very much for organizing this magnificent lecture. And I think I'm only to applaud the efforts of my students for working hard in very difficult situation to establish or to continue this service. And I wish you and others help them to go forward. And also we hope that our country will soon, all of us will go back. Thank you very much.
They're going to be using cement and brick.
Thank you very much. For those of you who don't know, Dr. Fidel, he is the father of gastroenterology in Sudan and a close associate for many years with Professor Siegel. And I think obviously it's quite a long time since the inception of the unit at the IDD at Baragwanath Hospital, where many of African trainees have trained. And we're doing a report on just exactly how that has developed in the country in terms of trying to train individuals from sub-Saharan Africa. And I think there's well over 40 trainees who have trained in South Africa who have gone back to their native sub-Saharan countries to take up the gastroenterology there. It's interesting that Abdul told us about initiatives in other countries, but I think there is a service in Ethiopia now. I think it's mainly based in the private sector. There's a service in Kenya, both in the private and in the public service. And we're going to Ghana and hopefully to Rwanda to develop services in those two areas. Nigeria, for 200 million people, has only 2 ERCP services for the whole country, apart from limited services in Lagos, usually run by expatriates who come back to provide the service. So there's definitely a deficit. There's a need for ERCP so people don't die from cholangitis and can get reasonable palliation for their jaundice. So I think there is a big need. That's what I'm doing in my pastime, in my retirement. There's a lot of heartthrobs here from Dr. Jafar.
I can see my team, all the team in Kassala City now. They are sitting. So I really appreciate what they are doing. Even Muhammad Jafar is the IT manager, and he behind many innovations we did. And all the team, Hala leading the team now in my absence is there. Hala, do you want to say anything? Hala, unmute. Hello, unmute, Hala.
We certainly can't hear you just now. You are unmuted, but we can't hear you. Oh.
Hala.
Hi, assalamu alaikum.
Hi.
Nice to see you and so happy to see you all. Prof. Fidel, Dr. Abdel Mounem, Prof. Sandy, we miss you all. Dr. Bassam, thanks for you. And really, we appreciate the effort that done by Dr. Abdel Mounem. Dr. Abdel Mounem is our mentor. And he's leading all of us towards a very nice destination. We hope that peace for Sudan, and we hope that all the
We look forward to seeing some of you from Sudan on iEcho in the future. There are lots of topics that would be of interest to gastroenterologists, not just endoscopy, and that occurs every week. Perhaps, Christian, could you tell us what the situation with ERCP is in Cameroon? Do you just have it in
Good,
the private sector, or do you have it in the public sector there?
Hi.
first, good morning, Abdo and
Hi,
Suleiman.
hi. Nice seeing you.
Happy to see you, and mainly Suleiman. We was very
Okay.
familiar in that
Yes,
time
yes.
with Ahmad. So good day to you all, and good day to
Thank you.
Sandy. Here in Cameroon, we have the same problem. We don't have any center. From time to time, we have some foreigners coming here from some ERCP, and we are trying to train some of our young gastroenterologists in this technique in France for now. Maybe we shall have to ask also for South Africa to help us in this side. But for now, we don't have any public system or private one doing this continuously.
There's definitely a deficit all over
Yes,
Sub-Saharan
yes.
Africa. Abdul,
Yes.
perhaps you've managed to get equipment and you've managed to adapt accessories, and I think that's something that individuals should do, because accessories and the supply of accessories and the reuse of accessories are definitely something that we need to do in Africa. This single-use items are really counterproductive to running a basic service for stone disease and simple stenting. So how could you tell us how you've managed to get the inventory that you've got? Because you've been much more successful than most other countries in Sub-Saharan Africa, including Nigeria and Ghana.
Yeah, since the start, I started the ERCP services, and we use my mentor, Professor Fidel, getting accessories from Europe and from UK, and we reuse the stent, we re-sterilize them, we make sure the quality of sterilizing and reusing them. But really, when you don't have the accessories, especially like pre-cut, and we managed to create it. We think how to create, because the idea is just to having a needle, so getting from snare or from synchrotome really was helpful. So because without doing this, the success rate, if you don't have pre-cut and you have the good experience to access with pre-cut, so definitely your success rate will be lower, definitely. And so we have to do something and to train our patients.
And do you have access to metal stents?
Yes, hopefully I have to thank our Minister of Health. Previously, we managed to get accessories to our friends from UK, from diaspora, sending many accessories, even expired accessories. Sometimes they don't use it, so we get it and we re-sterilize and use it. But now we get, in this time of war, very strong support from our Minister of Health, and we managed to get fully covered Boston Scientific even stents, and we are using it for our patients. So we have access to esophageal stent, metallic stent, and biliary stent as well.
And is that for patients who can afford it, or is it for your general patients?
We get support from the government now. All these cases I told you about is done free of charge. Free of charge for patients, but the government paying for the staff and for the center to maintain the service. Really is great help from
Ahmad, you want to say something? Hussam.
Yes, hi. Yes, hello.
Please go ahead.
Hi.
Hi, Abdel Mounem. Hi, the whole team.
Yes, hi, Hussam. When I went
hi,
to...
Yeah, so hi. My name is Hussam. I'm one of the gastroenterologists. And it's just a comment. I would like to congratulate and commend Abdel Mounem and the whole team in Kassala, without singling anyone out, for the amazing job they're doing. I've just been to the center last week, and And just comparing, you know, I was, you know, the set of my practice, I was working in the UK and then in the UAE, where all the consumable are available, and then just suddenly went there where you can see very limited resources. But I would say that the result is pretty much similar to what's happening, you know, in the UK or in the UAE. At the end of the day, they do fix the problem for the patient. They do draw a smile at these patients at the end. So congratulations, guys. I think you're doing an amazing job. And you know, I wish you just everything just carry on. And hopefully, you know, this war will end on one of the days. And it's definitely this is a great experience. And I'm glad that Abdel Mounem, that you know, you presented this talk just to reflect to the world that, you know, you can do something from nothing, basically. So well done.
Thank you, Hussam. And Hussam was coming to Sudan before the war, just 1 or 2 days before the war, to do the EUS service in Ibn Sina Hospital to help us to start it. We had a new machine, but the war started, and he faced many difficulties to get out the countries back to UK. So he came back now and helped us doing the list of ERCP while I'm in the state and to work together with our doctors in Kasala. So thank you very much, Hussam, really.
Yeah, thank you, guys. Yeah, well done, well done.
I'm looking forward they have a good network of Sudanese doctors doing ERCP and EUS, and they are ready to go to Africa and help, especially the US is not well established in Africa. So they are ready, really.
Yes. Again, one of the problems with the EUS is that the accessories are so phenomenally expensive.
Exactly.
Yes. And much more difficult to adapt.
Yes.
So again, and I don't know, again, obviously many of the countries have less than 5% of the individuals who are insured with health insurance. And so private practice is very limited for the population as a whole. But obviously they have resources. Do you think there's more that can be done with public-private partnerships? And how would you organize them? Maybe you seem to have a lot of governmental support, but that's not the situation, I think, in Ghana, and not the situation in Nigeria or even, well, maybe in Tanzania a little bit.
We have a good example of such support, because the police services in Sudan is a semi-private service. So we work together with them in establishing ERCP service in Port Sudan, and also patient to travel from Port Sudan to Kasala, is also long way to go. So we did this partnership with them. We support them as a center with accessories, and they are doing the procedure with subsidized cost, because we are supporting these accessories. So I think some sort of collaboration can work, and this partnership can help, because as a national center, I'm very much interested to spread the service everywhere to make it easy to patient to access the service. So you can collaborate with the private, you can collaborate with other like police or army hospitals. So I think such collaboration can work.
Yes, there's a collaboration up in northern Namibia. Again, it's a much smaller population, but an unserviced area, and that's a private-public partnership that they are trying to develop ERCP there. So I think thank you very much. It's nice to see your colleagues from Sudan and those diaspora who have been helping you and hopefully will continue to help you develop services. It's wonderful to see that. And personally, I take my hat off to you. I've been traveling around Africa a little bit and trying to do a small bit, but it pales into insignificance compared to what you've managed to achieve in your own sphere of influence and outside that. So thank you very much for doing the talk.
Thank you.
Thanks to everyone. Again, this is recorded, so if anybody wants to revisit it and have a look at it, it's on the Gastro Foundation website. And it remains me to thank Abdul again and to wish you all good hunting. And please visit the Gecko platform. There are lots of gastroenterology aspects to it, hepatology, pediatric gastroenterology, and many other aspects, pathology. So please look in on the on every Wednesday, and we will invite whoever wishes to participate. So thanks again, and goodbye to everyone. And thanks to the ladies who helped us with all that. Take care. Bye-bye.
Bye. Bye.